Hi, I'm Jack West, medical oncologist in Seattle, Washington. And I wanted to talk about a question that comes up pretty often in the context of immunotherapy, and that is whether these agents are different enough that we should care which of them we are prescribing, or whether all of the results we're seeing for the PD-1 or PD-L1 inhibitors are really a class effect and they're completely interchangeable. So, for instance, we have the newly reported results of the Pacific trial, which was with durvalumab, a PD-L1 inhibitor, given for a year after chemo and radiation administered concurrently for patients with locally advanced or stage 3 non-small cell lung cancer. And the question is, well, if we see these good results with durvalumab, we've seen a marked improvement in progression-free survival, not yet seen results for overall survival yet, can we just choose whatever immune checkpoint inhibitor we've used the most in the setting of metastatic non-small cell and then just import that in for a year instead of durvalumab, which is also known as Imfinzi? So I think that there's two ways to look at this, and one is, are these agents really that different? And I would say that I and most of the other thoracic oncology specialists, as well as immunotherapy specialists, think that these agents are really more similar than different. So when you look at pembrolizumab, Keytruda, or nivolumab, known as Opdivo, or atezolizumab, Tecentriq, or as I mentioned, durvalumab, which is also known as Imfinzi, certainly they have very similar efficacy overall in various trials and very similar side effect profiles. In the setting of previously treated advanced non-small cell lung cancer, nivolumab, pembrolizumab, and atezolizumab have all been compared to docetaxel as a second-line treatment and produced remarkably similar results overall. So in that setting, I think we have a bunch of choices and very comparable indications, and you could really interchange these very well. On the other hand, there are other settings. I mentioned durvalumab in stage 3 non-small cell lung cancer, where as of early November of 2017, we don't yet have an FDA approval, but expect that soon. Or say pembrolizumab as a first-line treatment in advanced non-small cell, either as a monotherapy for patients with high PD-L1 expression, or in combination with chemotherapy, carboplatin and pemetrexed with pembrolizumab for non-squamous non-small cell. These are all based on clinical trials, and we don't yet have data to support other immune checkpoint inhibitors being used instead of them. So I would say that if I had a patient who has completed chemo and radiation and I wanted to get durvalumab, but that was not possible, it was rejected by their insurer, but I happened to be able to give pembrolizumab or atezolizumab, I would feel fine with doing that and expect that the benefit would be remarkably comparable. That said, my preference would always be to treat with the agent that has the specific indication and has the best data. So if I could get durvalumab for stage 3 non-small cell lung cancer, that would be my preference. In first-line patients for metastatic disease, if someone had a high PD-L1 expression greater than 50%, I would favor giving pembrolizumab, and in fact, we have a trial with nivolumab, Checkmate 026, that actually failed to demonstrate a benefit compared to chemotherapy, and in that setting, for whatever reason, pembrolizumab fared better. So I don't think we could be completely cavalier about these agents being entirely interchangeable, even though they are really clearly more similar than different. So I think my preference would be to go with where the data are whenever possible. If we're thwarted because of practical issues like poor insurance coverage, then I think exchanging one for another, if that happens to be more feasible, is a reasonable possibility, but I think we should always favor what has actually been studied in that particular clinical setting. I would love to see direct comparisons of different checkpoint inhibitors in the same trial, but I don't think that's going to be, we're going to have that kind of data available anytime soon. We'll learn more, but for now, I would go with where we have the best data.